Hello, good evening. Today our first discussion in urology. We will discuss together eMRCS questions and we illustrate each question and differences and related questions as well. Okay, so I want you to share with me with the question and answer, and we will start with Dr. Abu Yazid. You can unmute your, okay. You ready? Then
Yes.
Dr. Shi, you will go with us also. Dr. Nashid as well. And anyone wants to share with us, he will just open mic. Okay, so we start with Dr. Abu Yazid. Okay.
Okay.
Start, please.
39 years old man noticed a swelling in his left hemiscrotum. On examination, he has left side varicocele. The ipsilateral tilt is normal on palpation. What's the most appropriate course of action? Scrotal exploration and ligation of varicocele, abdominal ultrasound, scrotal ultrasound, left auricodectomy, or discharge? I think abdominal ultrasound.
Okay, why?
Because it's always associated with renal tumor. Adenocarcinoma, something.
Okay. Why exactly?
Increase pressure and just make varicocele risky. I don't know the explanation.
Sorry?
I'm not
You
sure
don't know
about
the explanation of?
Yes.
Okay. And this, okay, so your answer is right. Why you do ultrasound and why you do ultrasound in abdominal? Because we have this swelling is in the left hemiscrotum, and why he said the left, because the left testicular vein pass directly to the left renal vein drainage. That's why it is very common
Left side
to have a tumor. Yes, to have a tumor in the kidney only presented with scrotal swelling, varicocele. But where is the right side drain? The right testicular vein or the right gonadal veins?
Yes, IVC.
Exactly. Exactly. So it's less common to find this problem. That's why it's we find more varicocele in the left side.
Left side, yes.
Because the pressure, the smaller vein, the range in the smaller vein, the left renal vein. That's why it's very common to find varicocele, and this is for all swellings suspected to be varicocele. We have to notice primary varicocele or secondary to renal tumor. That's why any presenting symptom is varicocele in the left side, especially, we have to do abdominal ultrasound. Okay, so next question. Dr. Shi. Okay.
Okay, so a 3-month-old boy is brought to the clinic by his mother, who has noticed a swelling in the right hemiscrotum. On examination, there is a firm mass affecting the right spermatic cord distally. The testis is felt separately from it. What is the most likely diagnosis? Inguinal scrotal hernia, rhabdomyosarcoma, Leydig cell tumor, torsion of testicular hydatid, hydrocele. E, hydrocele.
Hydrocele. So is it
I don't.
firm mass hydrocele?
No, it will be cystic type.
It will be cystic. Just go by exclusion if there is. I just want you to learn how to think in the exam for a new question. So this question is very common, and you have no related questions to confuse you. But I just want you to think. This is a new question. He is talking about a young boy. Okay, so
Yes.
we will think about tumors in early stage, in early days in life. Okay, so let's see. Inguinal scrotal hernia, yes, maybe in young age, but it is not firm mass.
Yes.
Okay. Next one, rhabdomyosarcoma, firm, yes,
Yes.
maybe. Okay. Leydig cell tumor, firm, yes. In the spermatic cord, no. In the testis itself, the testis is spelled separately from it, yes. So Leydig cell tumor is tumor from the Leydig cells of the testis itself, and the tumor is separated from the testis. So can be, no, can't be. Torsion of testicular hydatid, no. The boy is
No.
brought to the clinic by his mother. She noticed a swelling. So what is the complaint here? Just a swelling, yeah. Is it pain? Is the child is crying?
No.
Is there is black or dark color of the scrotum? No. So torsion of testicular hydatid is wrong. Hydrocele, is it firm? No. Is it separated from the testis? No. So by exclusion, what is the answer?
B.
Yes, exactly. Rhabdomyosarcoma. It is the only thing that is firm and separated from the testis, whatever it. The other four answers are wrong by exclusion, okay?
Okay.
Just learn to think about a new question you will face in the exam. It is very common to face about 30 to 40 questions in the exam, new, and you have to at least to get half of them or 50% from them right. Okay, next one. Okay, who's ready? Dr. Basharat. Dr. Basharat, are you ready?
A 22-year-old man presented with an... Hello? Can you hear me?
Yes. Yes, sir.
A 22-year-old man presented with an aching pain and discomfort in his right testis. He has felt systemically unwell for the preceding 48 hours. On examination, there is tenderness of the right testis. He has an exaggerating cremasteric reflex. What is the correct course of action? A, scrotal exploration via a scrotal approach. B, testicular inspection via an inguinal approach. C, administration of antibiotics. D, fine needle aspiration cytology. And E, reassurance and discharge. First, we have to diagnose it. What is the diagnosis? The diagnosis is epididymoarchitis. And for epididymoarchitis, we'll go for an administration of antibiotics.
So your answer is
Administration of antibiotics.
C, administration. Exactly. So this is a case of epididymolysis. Epididymolysis. So it will be administration of antibiotics. Okay. Next question. Who is ready? Rabul Yazid.
78-year-old man has a long history of nocturia, urinary frequency, and terminal dribbling. He was admitted with urinary retention and with catheterization. On removal of the cath, he has noticed some hematuria. What's the most likely cause? Transitional cell carcinoma, squamous cell carcinoma, polycystic kidney, renal carcinoma, benign prostatic hyperplasia. Benign prostatic hyperplasia.
Okay, so that's why did you choose this PPH?
Because it's common hematuria when removal of the cath, and there is no sign of tumor, no sign of carcinoma, and polycystic kidney usually associated with the other disease.
In the question, there is old age, 78 years. There is urinary frequency is increased, and there is terminal dribbling. It all goes for PPH.
Yes.
Yes. Okay. This is the cardinal signs for PPH. Also. Yes. Nocturia, urine frequency, terminal dribbling, and sometimes happen retention, and after catheterization from congestion happens the bleeding. So no signs of any tumor. No signs of any tumor here, and
yes.
Also polycystic kidney disease will give different picture with has no related to nocturia or urinary frequency or dribbling or retention. This is not a cardinal sign for urinary for renal cell carcinoma. Okay, next question.
Who's 32 years old.
Dr.
Who's start?
Okay, continue.
32-year-old lady suffers from a severe left side abdominal pain that radiates to her groin. As a part of evaluation, the nurse identified microscopic hematuria on dipstick. What's the explanation? Staghorn calculus, ureteric calculus, transitional cell carcinoma of the ureter, adenocarcinoma of the ureter, or cystitis. I think abdominal pain that radiates to the groin is associated with ureteric calculus.
Ureteric calculus.
Yes.
Okay, do you know why? Yes, it's right. Do you know why?
Explanation of the pain, the abdominal pain radiating to the groin, and hematuria.
Yes. No, why the pain radiates to the radiates to the groin or loin to groin pain, and is a common feature of ureteric acid. It is not why not Staghorn calculus.
Staghorn calculus are actually painless. The ureteric calculus, there are 3 levels. If the stone is in the upper level, the pain will be in the flank. In the middle, it will be in the loin. And if in the lower part, there will be increased frequency of urine.
Why radiates to the groin?
Because of this innervation of the nervous system. Because it irritates the.
Which
because
nerves?
it irritates the. Because the ureter wants to remove the calculus, it creates a spasmodic peristalsis, which is what you call which
Okay,
for example which
what nerve roots will give you this pain, radiate pain? Who know can raise hand and tell us? Sorry. Okay, so radiating pain. This is a question in iliohypogastric nerve. Radiating pain in loin to groin pain. It depends that the ureter or starting from the pelvis have a nerve supply. Have a nerve supply starting from. Just a minute, please. Nerve supply from T10 to L1. And this is the main dermatome starting from the umbilicus till the inguinal area. Inguinoscrotal area even. Inguinoscrotal. Okay. This is the sympathetic supply. This is the sympathetic supply of the ureter. That's why the ureteric pain give us a loin to groin pain. Okay.
Okay.
Clear.
Clear.
Why happens some nausea and vomiting with ureteric pain? Why happens this? Because the parasympathetic supply of the ureter from the vagus, and it supplies some part of the GIT up to the start of the left descending colon. That's why parasympathetic supply of the ureter is the same like the GIT. When irritated, gives the patient some nausea and vomiting. Okay, clear?
Okay.
Yes.
Clear? Okay. Next question, Dr. Shi. Anyone wants to share, please raise hand.
A 56-year-old man presents with urinary symptoms and on investigation is found to have a 2 cm nodule in the left lobe of the prostate. Imaging with whole body MRI and pelvic CT MRI demonstrate a likely cancer with no distant disease and no nodal metastasis. What is the most appropriate course of action? Open prostatectomy, B.
So you have a nodule, 2 centimeter, and you imaging by MRI and CT demonstrates like it's likely a cancer with no distant metastasis, no middle. Most appropriate course.
Yeah.
Oh, it's
Anyone
D.
has any
We
other
do a
answer?
biopsy, a prostatic biopsy first.
Perfect. Okay, that's right. No,
Yes.
no operation for the prostate without a biopsy. No operation without a biopsy. Okay.
Okay.
Why do we take a biopsy from the prostate? For prognostic, staging for the operation, and the level of aggressiveness of the tumor. Do you know what is the classification or what is the scoring system for the prostatic cancer? Sorry?
Gleason. Gleason score?
Gleason, exactly. Gleason score, yeah. You know what is Gleason score?
Yes.
Okay, what is Gleason score?
Scoring of 2 biopsy from 1 to 5. 1 is well differentiated and 5 is poor differentiated. And submission of the score of 2
Yes.
biopsy. 1 is less aggressive and 10 is aggressive. It's more aggressive.
Okay, so it is a score of 10, depends on the giving a score from 1 to 5 for the most common pathological cell type. Will give it a score from 1 to 5, and another 1 to 5 from the second most histological type or pathological type of the cells, and we calculate both together. And we give a score of 10. A score of 1 is the least aggressive, and the score of 10 is the most aggressive with the bad prognosis. Okay.
Okay.
Clear?
Clear.
Clear. Okay, next question. So, oh, sorry. Next question. Who's lucky? Dr. Basharat. Go.
Yes. A 49-year-old man presented with a single episode of hematuria. Investigations demonstrate adenocarcinoma of the prostate gland. Imaging shows T2 disease and no evidence of metastasis. What is the best treatment option? A, chemotherapy alone. B, radical prostatectomy. C, transvesical prostatectomy. D, TURP. And E, external beam radiotherapy. As the diagnosis is already made and it is already no evidence of metastasis, we'll go for a radical prostatectomy.
Exactly. So we don't give chemotherapy alone. Patient is young age and he has no comorbidities. Transvesical prostatectomy or TURP, both of them are not applicable for cancer prostate. External beam radiotherapy also. The patient is fit for surgery and young age, so surgery will be the best answer. Okay, so radical prostatectomy, you are right. Okay, next question. Dr. Yazid.
38-year-old man is investigated and found to have a left side renal mass. Imaging demonstrates a 5 cm renal tumor invading the left renal vein. There is no evidence of distant disease. What is the most appropriate course of action? Radical nephrectomy. B.
Okay, anyone has a different answer? Okay, yes, exactly. Why didn't take a biopsy here? No. Okay, exactly. It is not a common practice to take a biopsy from the kidney. Most kidney tumors are classified and diagnosed by CT and imaging studies. Okay?
Okay.
So radical nephrectomy is right. Okay, next, Dr. Shi.
A 52-year-old man falls off his bike. He is found to have a pelvic fracture. On examination, he is found to have a perineal edema, and on PO, the prostate is not palpable. What is the most likely underlying problem? I think it's I'm not sure. E. Membranous urethral rupture.
Okay, anyone have different answer? I can see in chat.
No.
E. Dr. Mariam D. No. Okay. Right answer, membranous urethra. Okay. Let's see what you'll have questions here in related to urethral injury. You have two scenarios. One scenario, you have two scenarios. One scenario will tell you one scenario will tell you the patient see prostate. Okay, just a second, please.
Okay.
One scenario will tell you the prostate high up. Okay, in digital rectal examination. And so this is the membranous urethra. Okay. So this is a membranous urethra. The other scenario will tell you the patient fell down with legs apart or on a bike.
Mm-hmm.
So he will not tell you about the urethra. You will find, yes, a perineal and penile hematoma, and this will be bulbar urethra. So apart B will be bulbar, or bike will be bulbar. Prostate up can be felt will be membranous. Okay.
Okay.
Next question. So this is only two scenario.
And for me,
who's next? Okay, Dr. Basharat.
Why is a 73-year-old lady receiving a course of intravesical BCG therapy? Bladder tuberculosis, transitional cell carcinoma of the bladder, adenocarcinoma of the bladder, squamous cell carcinoma of the bladder, rhabdomyosarcoma of the bladder. Intravesical BCG chemotherapy is given for transitional cell carcinoma of the bladder. B.
Exactly. Transition cell carcinoma when superficial. Sometimes we give the BCG therapy through a urethral injection. Okay. Next question, Dr. Shi.
A 70-year-old man presents with hematuria, which is recurrent. On investigation, a retrograde bielogram shows multiple ureteric filling defects, and the renal pelvis is irregular. What is the most likely cause? Transitional cell carcinoma. B.
Okay. Okay. Why you said this?
Because in this age group and the ureter has multiple filling defects, and the irregularity of the renal pelvis should indicate to a carcinoma. And
Yes.
the common carcinomas will be the transitional cell carcinoma.
Exactly. Transitional cell carcinoma is the most common carcinoma, most common type of urothelial tumors, followed by squamous cell carcinoma. Squamous cell carcinoma in cases of chronic irritation. Okay.
Yes.
If he tell you, frankly, we found a tumor in the urothelium, which is starting from the pelvis, ureter, and the bladder. So the most common is the transitional cell carcinoma. But if he mentioned in the scenario, the patient has chronic stone and bladder, chronic stone in the pelvis, staghorn for a long time, or chronic bladder stone, what is the most common? Will be squamous cell carcinoma.
Squamous.
If he tell you the patient, yes, if he tell you the patient have chronic bilharziasis or something like this, or coming from endemic area with bilharziasis, also you will have squamous cell carcinoma. So any chronic irritation will be squamous cell carcinoma. Otherwise will be transitional cell carcinoma, which is the most common. Okay.
Yes.
Okay.
Okay, this is solved, but we will have to say so. Dr. Abu Yazid, you can read the question, please.
What is the most useful test for 5-year-old who has a vesico-ureteric reflux in whom there are concern about the potential of renal scarring? Renal scarring.
Yes. Yes. Dimsa Scan.
Yes.
Okay. Let's talk about some investigations of the some investigations here about the kidney. We have the most common investigation you will face here is what's called Dimsa Scan. Okay. Dimsa Scan is a substance that is concentrated in the renal cortex, and less common concentration, or the concentration in the medulla and pyramids, is low. That's why it is the best investigation if I want to assess the cortical thickness or any cortical scarring due to pelviureteric junction obstruction or vascular reflux. So what is the keywords for to choose Dimsa Scan? Renal scarring. Okay. Number 2, pelviureteric junction obstruction. Number 3, vascular-ureteric reflux with hydrokidney. So any one of these 3 will direct you to Dimsa Scan. Okay. Next one, MAG 3. Maxillary is a substance that secreted by the renal tubules. Even if the glomeruli are damaged and the filtration are damaged, this substance is secreted. So we depend on it to assess renal function, secretory function of the kidney. Okay, if he is asking about secretory function of the kidney or it is a functional kidney, so we will go for maxillary. So renal function, maxillary. Renal scarring, pelvic junction of assessment of kidney or vascular reflux, we'll go for Dimsa scan. The last one is CT, any renal tumor. Renal tumor, we'll do a CT scan with contrast, plus contrast. Stone, whatever, kidney, ureter, bladder, especially the ureteric kidney, the ureteric stone, you will do CT without contrast. Clear?
Clear.
Okay. That's according to the imaging investigations you will face here. But sometimes we will face one question that the patient has pelvic junction obstruction and he went to one doctor, which you go direct for the CT. And the patient did a CT and he'll find some scarring. This is a question, by the way. Patient have pelvic junction obstruction and he did a CT, okay? The CT revealed scarring. Yes, you are right. The revealed scarring. What is the next investigation? So the CT gives us the anatomical problem. So what we'll do next, you want to know with this scarring, is it still function or not? So you'll go for maxillary to know if the kidney back. Why I didn't go for Dimsa? Because you will find Dimsa in the question. So the Dimsa will give me the same result like the CT. It will give me scarring, but the CT is higher than Dimsa scan. Okay, with less radiological exposure. That's why we start with Dimsa scan followed by the CT. But here the doctor just asked for CT, and with the CT he found that it's scarring. So what is your next step? So my next step to see if the kidney is function or not function. Okay? Clear?
Okay. Clear.
Anything is not clear? Okay. So next question, who? Dr. Basharat, where are you?
Okay.
Yes, okay.
A 28-year-old man presents with pain in the testis and scrotum. It began 10 hours previously and has worsened during the time. On examination, he is pyrexial. The testis is swollen and tender, and there is an associated hydrocele. What is the most likely diagnosis? Torsion of the testicular hydated, torsion of the testis, testicular seminoma, acute epididymoarchitis, and torsion of the spermatic cord. As the patient is 28 years, he's in pain, testis and scrotum since 10 hours and worsened during that time. He has pyrexia, that is, we will go for acute epididymoarchitis.
Exactly. This pain and since 10 hours, and the patient has fever and increase by daytime. Increase by daytime, he means that during the patient is standing,
Yes.
the pain increase. And we all know that testicular pain is decreased by testicular elevation. So that's what he meant by, exactly. So fever, 10 hours, young age in the youth age, adolescent age, and associated with some sort with hydrocele. That's acute epididymolysis, or torsion. All of this will come with severe pain, and fever will not be a presentation. Also, testicular seminoma will come with no pain and no fever as well. So by exclusion, acute epididymolysis is our answer. Okay, next question, Dr. Abul Yazid.
A 20-year-old male notes a mild painful swelling of his right scrotum. He also complained of abdominal pain clinically. The patient is found to have swollen right testicle apart from a supraclavicular node. There is no obvious lymphadenopathy. What's the best course of action? Orchidectomy via an inguinal approach. D.
Orchidectomy via inguinal approach. Why not through a scrotal approach?
I think it's not accessible.
Okay, you are right. It's accessible, but we always clamp the spermatic cord from its origin at the internal ring to ensure complete safety margin of the testicular tumor, as there is no connection between the testicular lymphatics and the scrotal lymphatics. That's a very important thing here and in part 2. There is no biopsy through the testis, through cut biopsy or something like this, because the testis and the scrotum completely separated lymphatics and drainage and the blood supply. And when you just cut the testis by its cord from the internal ring, you have no spreading to the scrotum. But any maneuver you will try to do by biopsy through the scrotum or a scrotal approach to ligate or cut the testis with spermatic cord, you will have not enough safety margin, and also you may spread to the testis, to the scrotum and surrounding tissue. So orchidectomy is done through inguinal approach. What is the most common here? It is teratoma, and just to know, we have two
Two group of testicular
common tumors, 3 common tumors, testicular tumors you will face here, and in part B you have 3 types from 20 to 30, from 30 to 40, and above 60. From 20 to 30 what? Teratoma. This is the most common. So 20 teratoma, okay, TT. From 30 to 40, seminoma. So 30 S. Above 60, it is most commonly will be lymphoma of testes. Okay.
Okay.
20 to 30. Again,
Teratoma.
it's clear.
Yes.
Yes.
20 to 30, teratoma. 30 to 40, seminoma. More than 60 age, it will be lymphoma.
Lymphoma.
What type of lymphoma? in old age? Non-Hodgkin lymphoma.
Mhm.
Clear?
Clear.
Yes.
Anyone want to ask or something not clear can just raise hand, please. Oops. Okay, next question. Dr. Shi.
Okay. An 83-year-old man with a long-standing staghorn calculus presents with recurrent hematuria, and investigation shows a mass of the left renal pelvis. Of the lesions listed below, the diagnosis is A. Squamous cell carcinoma,
Exactly. I think we just cleared about this.
Yes.
irritation due to the staghorn calculus.
Exactly. If you just mention in the question that we have a chronic irritant lesion, so we'll go for squamous cell carcinoma. Okay. Next question, Dr. Basharat.
A 75-year-old lady reports urinary incontinence with coughing and sneezing. She has had 2 children with no complications. She has no significant past medical history and is on medication and is on no medication. What is the most appropriate initial management? Trial of sacral neuromodulation, urodynamic studies, pelvic floor exercise for 3 months, bladder drill training for 6 weeks, administration of oxybutynin. As in the question, they are telling us that the urinary incontinence is with coughing and sneezing. That means she has stress incontinence, already it is there. So we'll go for a pelvic floor exercise for 3 months.
Exactly. You have 2 scenarios about incontinence. Okay. One scenario is telling about, or actually 3 scenarios about incontinence. First
First,
scenario
urge
you'll
and
face
medication.
here, which is, sorry, I'm talking about the scenario we will face. When he tells you stress incontinence, that's you will go for pelvic floor exercise. What's name of the training or the exercise? Anyone know? Exactly, Dr. Mumtaz. Kegel's exercise. The other scenario will give you the patient has continuous dribbling and a history of obstructed long delivery, vaginal delivery. Here, the most common diagnosis will be
Fistula.
vaginal fistula from obstructed labor. Another one will tell you just incontinence for unknown cause and during day or with stress. And what investigation you will do? You will go for urodynamic studies. This is the 3 scenarios you will face about incontinence. Okay?
Okay.
Okay. Next question. Dr. Abul Yazid.
Yes. Which of the following renal stone types is most radiodense on plain X-ray? A. Calcium phosphate.
Exactly. Renal stones.
Calcium oxalate is most common
We
in
have-
general.
Yes. Okay,
Uric
let's
acid.
take one and one. Okay, calcium
Yes.
phosphate. Yes.
The only
Okay,
radiolucent.
calcium phosphate.
Uric acid.
Okay. Calcium phosphate, most dense. Uric acid, most radiolucent.
Mhm.
Struvate stone, renal pelvis with chronic infection. So he will tell you the patient has chronic recurrent infection.
Mhm.
Okay, so we'll convert the media to with the chronic production of urease enzyme to more alkaline, which is a good media for struvate stone to be formed. Cystine stone, a very common with
Hereditary.
hereditary, exactly. So he will tell you this hereditary problem. This is mostly recessive, autosomal recessive, okay, trait. The patient will see that father or mother have the same problem. So it's very common with hereditary problem in cysteine metabolism. So the patient would have hereditary, will have a cysteine stone. Another one is the urate stone. Urate stone, by the way, urate stone, you'll find it patient has a problem in metabolism, like cancer patient or patient receiving chemotherapy that will have a high urea in his blood. That's why he will have a urate stone. Urate stone associated with cancer or chemotherapy. Is it clear?
Yes.
Or repeat again?
Yes.
Clear. Okay. Next question. Mr. Bashrat.
A 32-year-old male presented with a swollen right scrotum, which has developed over 3 weeks after being kicked in the groin area. There is no tense swelling of the right scrotum, and there is a non-tense swelling of the right scrotum, and the underlying testis cannot be easily palpated. A dipstick is positive for nitrates only. What is the most likely diagnosis? Epididymoorchitis. A. B. Testicular torsion. C. Torsion of the testicular appendages. D. Hydrocele, and E. Hematocele. Patient has been kicked 3 weeks. There is history of trauma. I will go for E. Hematocele.
Okay, after 10 days, after 3 weeks, sorry.
Yes.
After 3 weeks, we will present with hematocele.
No.
Okay, let's take the answers.
It is hydrocele.
By exclusion. Yes, exactly. It's hydrocele. Let's go by exclusion. It's a new question and I asked. Epididymoorchitis. What is the main complaint of the patient? Swelling. Yes?
Fever.
Just a swelling.
Yes.
There is no tense, no fever, nothing. Just swelling. And history of trauma 3 weeks ago. Epididymolysis, no fever, no pain. Testicular torsion, no pain.
No.
Torsion, testicular appendage, no pain. Hydrocele, maybe. Hematocele, maybe, but hematocele scenario is few hours or after 1 hour of the trauma. And mostly if some bleeding happened from the trauma, it will be painful. So will be painful, swelling soon
Intense
after
swelling.
trauma. Whatever, tense swelling, even if small leakage, but it will be a painful swelling which happens early after trauma. So by exclusion, hydrocele. This is what is called secondary hydrocele after trauma, because some sort of edema will happen in the testis. The edema start to resolve. Fluids of the edema will be collected in the vaginal space. That's why you will find what's called post-traumatic hydrocele. Okay, like you remember, if you just shared with us the orthopedic stations, you remember what about knee trauma? And the patient, he is playing and suddenly he have a torsion of his knee or a knee trauma, and then the patient had a swelling 2 days after or 1 day after the trauma. What it will be? Meniscal tear with edema. Okay. And the other scenario, the patient have twisted knee or trauma to the knee, and immediately the patient have swelling of the knee. What it will be? Hemorrhagosis due to
Patellar.
rupture cruciate ligament.
ACL.
Cruciate ligament, ACL or PCL. Mostly will be PCL or whatever. But I'm just want to differentiate meniscal tear with edema after 1 day, and also hemorrhagosis, which will be few minutes or 1 hour after the trauma. It will be a cruciate ligament plus tear in the cruciate ligament. This is the same scenario, by the way. Immediate hematocele. After a few weeks or few days, it will be post-traumatic hydrocele. And this is the two only scenarios that you will have. Okay, next question. Whose turn?
Dr. Shi.
Yes, go.
A 52-year-old male with hypercalcemia secondary to primary hyperparathyroidism presents with renal polyp. Ultrasound demonstrates ureteric obstruction due to a stone. Multiple attempts at stone extraction are performed. However, the stone couldn't be removed. He is now septic with a pH of 39.5 degrees, and he has been given antibiotics. What is the best course of action? Insertion of a nephrostomy.
Yes.
Exactly.
See? Yeah.
Why is this? Why is this?
Because he had a ureteric obstruction due to the stone, and he is now septic with fever of 39.5. So most probably he has pus. He's having pyelonephritis, and
Can be extracted.
so the next step will be to relieve the obstruction and insert the nephrostomy.
This is a critical surgical scenario. Like the patient have abdominal abscess, what you'll do, you'll go to drain the abscess, and you'll not go for the definite treatment if you can't reach from where the abscess or something like maybe intestinal fistula or something like this. You'll go first to drain the abscess and then search for the problem. The patient has infected sebaceous cyst with abscess. You'll drain the abscess and then you'll go to remove the sebaceous cyst. That's exactly. Here the patient is critical, sick patient, septic, and all other options, it will be time consuming and may fail or succeed. So cystoscopy and insertion of ureteric stent, no. you will have the patient is good condition, so you'll go for this, and even the stent can pass or can't pass. Laparotomy and ureteric exploration. No, it is not. It is not common in a septic patient with about almost 40-degree fever. Laparoscopic ureteric exploration. No laparoscopy, no anesthesia. We'll try to give anesthesia for a patient septic, and also lithotripsy. It is not common with patient septic, and we'll try to fraction the stone is not common. So insertion of a nephrectomy tube is very common and can be done by interventional radiology with very little sedation or just general anesthesia for a few minutes to relieve the obstruction and relieve the fever, and then the patient can go for the definite treatment. Okay, so insertion of nephrostomy tube. It's clear about nephrostomy, or anyone can understand what is nephrostomy?
It's like a drain.
Is it clear?
Yes.
Okay,
Clear.
nephrostomy just go through the skin, through the kidney, and put the drain inside the pelvis to drain outside the septic fluid or the septic urine, because it can't pass through the ureter. Okay, next question. Who?
A 56-year-old man is involved in road traffic accident. He's found to have a pelvic fracture. He reported that he has some lower abdominal pain. He has peritonism and lower abdomen. The nursing staff reported that he has not passed any urine. A CT scan show evidence of free fluid, which is most likely diagnosis. B, bladder rupture, because there is no urine pass.
Okay, involved road traffic, pelvic fracture. So with pelvic fracture without a bladder rupture, he reports that he has some lower abdominal pain. Okay, peritonism. Okay, and nursing staff reports. So bladder rupture is which type of bladder rupture? Intra or extraperitoneal?
I think extraperitoneal.
Intraperitoneal.
Intraperitoneal.
Intraperitoneal. He has peritonism.
Intraperitoneal. The patient has peritonism. Exactly,
Yes,
peritonism.
yes,
What
yes,
is
yes,
different
yes,
between
yes, yes, yes.
extraperitoneal and intraperitoneal? Extraperitoneal, the patient has distended lower abdomen and with no signs of peritonism. Intraperitoneal, the patient, you will make an ultrasound, you will find an empty bladder with collection fluid inside the peritoneum. So this is intraperitoneal rupture.
Okay.
Okay, just take care, because I think I see some question in recalls related to bladder rupture. What is extraperitoneal and intraperitoneal? Okay.
Okay.
The patient extraperitoneal, the patient will have severe pain. Patient will have severe pain and tense swelling in the lower abdomen, and can't pass urine because loss of connection with the urethra sometimes.
Okay.
Next question, Dr. Basharat.
A 58-year-old man has an episode of painless frank hematuria while undergoing a 24 urine collection for investigation of hypertension. What is the most likely cause? Renal adenocarcinoma, neuroblastoma, transitional cell carcinoma of the ureter, squamous cell carcinoma of the bladder, pheochromocytoma. I will go for a renal adenocarcinoma because hematuria associated with hypertension.
Okay, why hypertension here?
Hypertension may be because of the stenosis of the vessel. It causes the innervation of the angiotensin system.
Okay, one cause, the other one. exactly, paraneoplastic. It is written here, by the way, and in the comment. It's mainly renal cell carcinoma. It's mainly renal cell carcinoma is one of the most common tumors represented with paraneoplastic syndrome. One of them, by the way, is hypertension. So hematuria, loin mass, hematuria, hypertension is pathognomonic signs for renal cell carcinoma by name. Okay, what's called renal adenocarcinoma or renal cell carcinoma.
Okay.
Next question. Who is doctor? Dr. Shi?
Okay. A 34-year-old
Hello?
woman from Chad presents with continuous dribbling incontinence after having her second child. Apart from prolonged labor, the woman denies any complications related to her pregnancies. She is normally fit and well. What is the most likely diagnosis? Vesicovaginal fistula.
Exactly, we just
Vesicovaginal.
explained in this.
Yeah.
Yes, exactly. He will present with dribbling incontinence plus prolonged labor, which denies complication rate. Okay, prolonged labor. This is a pathognomonic for suspected vaginal fistula. Stress incontinence, it will not be continuous. Overactive bladder also will not be continuous and will be associated with other neuropathic problem or something like this. Colovesical fistula will be represented with fecal. No, colovesical fistula, no, this will be represented with pneumovasicum or sometimes fecal material in the urine. Pudendal neuropathy also will cause something like overactive bladder or incontinence. It will be continuous, but more with pudendal neuropathy will have also problem in the bowel habits. It will be associated also with maybe fecal incontinence as well. Okay.
Okay.
Next question, doctor. I need new participant to start. Dr. Nashid, Dr. Zaina, Dr. Mumtaz, Dr. Mariam, Dr. Jeffrey, Dr. Nashid, okay. Go, unmute yourself and go.
A 23-year-old woman is admitted with loin pain and a fever. She has noticed hematuria for the past week, accompanied by dysuria. This was treated empirically with trimethoprim. What is the most likely cause? Stone disease, cystitis, pyelonephritis, renal cancer, detrusor instability. Hematuria, loin pain, fever. Pyelonephritis, I think it's the pyelonephritis.
Yes, exactly. So pain and fever and loin site of pain and fever gives us this is a kidney infection. So it is stone kidney, stone disease? No, it is
No.
cystitis, will have a suprapubic pain. It is renal cancer, it will not come with fever. It is detrusor instability, it will be something like So propiopic problem, not renal. So loin pain and fever, the only thing will be infection in the kidney, which is pyelonephritis. Okay, next, who needs to share again? Dr. Zaina. Dr. Zaina, are you ready? Okay. Okay. Dr. Nashid, go for the next question.
Okay. A 75-year-old man presents with locally advanced carcinoma of the prostate and vertebral body metastasis with impending spinal cord compression. Which of the following agents, if used in isolation, carries the greatest risk of worsening his symptoms in the short term? Surgical orchidectomy, mm, crypt- mm, I can't read. Can you please zoom? It's cyproterone acetate. Okay, cyproterone acetate, luteinizing hormone releasing hormone analogs, flutamide, and none of these above. Okay, I'm not sure about it. Maybe it's C. Luteinizing hormone releasing hormone analogs.
Okay. Yes, exactly. Okay, this question is confusing question, and some of your friends sent me a few days ago. Why did we choose luteinizing hormone releasing hormone? Okay. Treatment of prostatic cancer or active prostatic cancer, we will go for what's called androgen ablation, or we just want to suppress the androgen. Okay, we have some drugs like flutamide and cyproterone. This is androgen blockers that can be considered to be, when you give to the patient, it will block the androgen secretion, but it will block the testicular androgen, but it will not block the androgen which comes from the renal cortex, sorry, the adrenal gland cortex. But if anyone has noise background, please mute. Okay, but luteinizing hormone releasing hormone analog is an androgen blocker, but its action depends on, first, it makes flaring of the androgen in the start of treatment, followed by suppression. Flaring, followed by suppression by the negative feedback process. And this flaring of the androgen, is very dangerous because it may flare the tumor. So when you start to give the patient LHR hormone analogs, you have to start with other drugs like flutamide or cyproterone, so you will avoid the time of the flaring of the androgen and the flaring of the tumor. It will be blocked till its action starts to make blocking of the androgen release, and so you can stop flutamide and cyproterone. So giving luteinizing hormone, releasing hormone only in the start of treatment, it may make the problem more hazardous. Okay, is it clear?
Yes, it's like heparin and warfarin. Like we use heparin with warfarin.
Yes, something like this. You give both together because the problem may be heparin, warfarin, because warfarin is not start working, and heparin will cover it. But the problem here is that you will have a disaster if you started luteinizing hormone, releasing hormone alone and the flaring. So you may have something like disaster flaring of the tumor.
Okay.
Okay, next question. Start again, Dr. Abu Yazid.
Yes. 42-year-old man
Go.
underwent a vasectomy at surgical clinic. He is reviewed at the request of his general practitioner. On examination, he has small rounded nodule adjacent to the vas. What's the most likely underlying diagnosis? It's common after vasectomy, sperm granuloma.
Exactly.
That would be P.
Just a simple question. Yeah, simple question has no related questions to confuse. Okay, sperm granuloma is common, like nerve granuloma happens after any nerve trauma. This is sperm granuloma. Next question, Dr. Basharat. Go. Dr. Basharat, are you ready? Unmute yourself, please. Okay. Dr. Shi.
A 15-year-old boy develops a sudden onset of pain in the left hemiscrotum. There is no other urinary symptoms. On examination, the superior fold of the testis is tender and the cremasteric reflex is particularly marked. What is the most likely underlying diagnosis? C. Torsion of a testicular hydatid.
Okay. Speech pole of the exactly, because this is not the epididymoid, so the patient has the main problem, pain in the left hemiscrotum, no fever, so it is not epididymoid. Not severe pain, it is torsion, it will be acute pain, and the cremasteric reflex may be lost in torsion. Torsion of testicular appendices or testicular hydatid is the most common because the swelling is just above the testis. Viral orchitis not with a swelling. Testicular malignancy, this is the swelling is above the testis. Okay.
Okay.
Next question. Dr. Basharat, ready? Go.
A 32-year-old male presented with a swollen, painful right scrotum after being kicked in the groin area. There is a painful swelling of the right scrotum and the underlying testis cannot be easily palpated. What is the best course of action? A. Inguinal orchidectomy. B. Scrotal orchidectomy. C. Scrotal exploration. D. Testicular ultrasound. And E. Testicular aspiration. I think the best course of action will be scrotal exploration.
Exactly. This is a patient swollen, painful right scrotum immediately after
Trauma.
a kick, okay, after trauma, and this painful swelling, and it can sometimes you can't examine the patient. No way that you will wait to do some investigation for something like this because you doubt two things, maybe hemoscrotum, okay, hematocele, or sometimes happens like torsion of testis post-trauma. Post-traumatic, sometimes torsion testis happen associated maybe some congenital anomalies with the testis or susceptibility for the torsion, and it's very common after trauma that happens this problem. So surgical exploration is the best choice for this. Okay. Next question. Go again for Dr. Nashid.
Yes. A 33-year-old
Okay.
man presents with a A 33-year-old man presents with a painless lump in his left testis. USS and blood tests are suspicious for teratoma. What is the most appropriate next step? Orchidectomy via an inguinal approach, orchidectomy via scrotal approach, fine needle aspiration cytology of the lesion, core biopsy of the lesion, incisional biopsy of the lesion. Orchidectomy via an inguinal approach.
Exactly. We said we can do any scrotal approach for any testicular tumors, and also biopsy, fine needle or core biopsy or incisional biopsy are completely contraindicated in any testicular tumor. So orchidectomy by an inguinal approach is the right answer. Next. Dr. Abu Yazid.
Yes. A 23-year-old man present with severe loin to groin pain. Imaging demonstrates a 2 mm left side calculus in the distal ureter. Renal function is normal. What's the most appropriate course of action? Review patient in 2 weeks because it's 2 mm.
So no lysotripsy, no nephrolysectomy, no extraction, no ureteroscopy. Okay. Exactly. This is the answer. Yes. This is 2 mm stone. So you will do just a QP and follow up with the patient with good hydration and follow up for the descent of the stone. Okay, this is a very important question, and we will go for tumor size. We have two types of stones, and how we'll manage here. This is very important tables, by the way. First one is renal stones, and actually both of them are the same mostly. If you have a stone from up to 5 mm, from 0 to 5, in both places, these stones mostly will go with some medication and good hydration of the patient, will go through the normal pathway of the ureter and the urinary bladder and the urethra. The other one, if you have one from 5 mm up to 10 mm, you may go for extracorporeal shockwave, lysotripsy, because it's up 10 mm, 11 mm. The extracorporeal shockwave can distract this stone to small gravities and can pass with the urine. From 10 to 20, it depends. It depends. You can, I tell you, maybe 10, 11, 12 or more than this. You can do as well sometimes. Or you can go with endoscopic treatment. You go and the endoscopic procedures through ureteroscopy or ureteroscopy. So you can catch this stone by a Dormia basket. You can fragment this stone and extract the fragments. But more than 2 centimeters or more than 20 mm. So you can't do this by as well or by ureteroscopy. So you'll go for the open technique by percutaneous nephrolysectomy or open ureteric exploration and extraction of the stone. So is it clear? 0 to 5, watchful waiting, 5 to 10 as well, 10 to 20 according starting the curve from as well, till endoscopic pathway more than 2 centimeters stone, you will go for the open technique for the kidney, PCNL or percutaneous nephrolysotomy, or open ureterolysotomy. Okay. Next one.
Okay.
Who's third? Dr. Basharat.
A 67-year-old man presents with recurrent episodes of hematuria, typically at the end of the urinary stream. He has been suffering from occasional fevers and has noticed pus on the urethral meatus on occasions. On examination, the prostate has no discernible masses, but is tender. What is the most likely cause? A, prostatitis, B, cystitis, C, BPH, prostate cancer, or nephritis. As the patient is 67 years and there is blood at the end of the urethral stream with occasional notes of pus in the urethral, we will go for prostatitis. A.
Exactly. Fever, pus, and the urethral meatus, hematuria, and tender prostate. This picture does direct our thinking for the prostate problem. So is it prostatitis or PPH or prostatic cancer? So nephritis excluded, cystitis excluded. So is this PPH? So why painful and why pus? Is it prostatic cancer? The same, why painful and why pus? So we're searching about the prostatic problem, which will be most commonly the prostatitis. Okay, this is just the way of thinking in your mind. Next, Dr. Shi.
A 22-year-old man is involved in a road traffic accident. He is found to have a pelvic fracture. While on the ward, the nursing staff report that he is complaining of lower abdominal pain. On examination, you find a distended bladder. What is the most likely diagnosis? Bladder rupture?
Oh,
Oh, sorry, it's distended bladder. So it is prostate rupture, urethral injury. Sorry, urethral injury.
Urethral
Yeah,
injury.
urethral injury.
Exactly. The patient has intact bladder. Okay. So
Yes.
he misconnects the connection, the disconnection between the bladder and the urethra. So it will be urethral. So it is not ureteric injury. It is not common with the pelvic fracture to have a ureteric injury. Bladder rupture, no. Full bladder. Urethral injury, no. Clot retention, no. We just don't have any problem with the bleeding inside. You have full bladder, nothing inside the bladder like bleeding or something like this. Prostate rupture, I didn't see before, by the way, prostatic rupture. And I don't know even how the prostate may be ruptured. Okay, so urethral injury is the most common. And the most correct answer. And next question, Dr. Nashid again.
A 44-year, the question is gone. A 44-year-old man is referred to the clinic because of swelling and discomfort in the right scrotum. This is present most of the time and he is otherwise well. No urinary symptoms. On examination, he has a soft fluctuant swelling in the right scrotum that transilluminates easily. An ultrasound is performed that confirms that that the underlying testicle is structurally normal. What is the best course of action? Ligation of patent processes vaginalis by inguinal approach, ligation of patent processes vaginalis via scrotal approach, Jabuli procedure via scrotal approach, Lord's procedure via inguinal approach, aspiration and injection of sclerosant. C. Jabuli procedure via scrotal approach.
Okay. So this is a case of what diagnosis? What's your diagnosis?
Hydrocele.
Exactly. And the hydrocele, we have two options for, and what is the options for treatment of hydrocele?
Jabelis and Lords.
Jabali and Lord.
Exactly. And both of them through
Scrotal.
The scrotal approach.
scrotal approach. Okay. When we do hydrocele operation through an inguinal approach,
In babies, when there is a congenital
hydrocele.
pediatric surgery. Pediatric surgery up to 5-6 years sometimes, and up to 7 years according to the baby's and the child size. We can make it up to 6-7 years, 8 years sometimes if the child is size or body is small. So we can go for inguinal approach. You deliver the testis and the surrounding hydrocele, and you make the operation, and you put rest it back in the scrotum. But in adult, we go through a scrotal approach by Jabali or Lourdes operation. Okay, so this is Jabali through scrotal approach. So you search for a scrotal approach and see which operation, whatever Jabali or Lourdes. There's no, it is not out of our scope to know the difference between them and some operation. Okay. Next question. Who? Again, Dr. Abu Yazid.
Which of the following would be most consistent with like histological aggressive form of prostate cancer? We mentioned that before. Score 10, Gleason score of 10.
Yes. Exactly. So 10 is the aggressive, most aggressive, and the worst prognostic score, and score of 1 or 2 is the best prognostic and the least aggressive one. Next. Dr. Basharat. Okay.
A 13-month-old boy is brought to the pediatric clinic by his mother, who is concerned that his testes are not palpable. On examination, his testes are not palpable either in the scrotum or inguinal region and cannot be visualized on ultrasound either. What is the most appropriate next step of management? A, laparoscopy. B, reassess at 5 years of age. C, reassess at 13 years of age. D, administration of testosterone. E, administration of proteron estate. We'll go for laparoscopy to find the testis. A.
Okay, laparoscopy actually is diagnostic and laparoscopic, and diagnostic and diagnostic and
therapeutic. Sorry? Diagnostic as well as therapeutic.
Exactly. Yes, exactly. The other thing we can have, but he doesn't want to confuse you. Another investigation sometimes we do, what is the CT, abdomen and pelvis. Okay, but here
yes,
doesn't mention about the CT. But if there is CT, okay, sometimes we do CT before any invasive
laparoscopy. Before any invasive procedure, we should go for a non-invasive. Actually, before
yes, exactly.
any
sometimes we do CT because yes.
Actually, before
because
any non-invasive procedure, we should go
but
for
here is CT. Okay, so that's why we did choose laparoscopy here, because this is the most common after CT to go with, and it is diagnostic and therapeutic at the same time. But actually, CT is the most accurate if you don't have any broad idea about what you will go for the laparoscopy. Okay.
If you mention in the answer laparoscopy and CT, which one to choose?
It will not mention. He will not confuse you, and he will not confuse, and he will not. It is out of scope because it is a debate between urologists where to go for CT first or laparoscopy first. But actually, CT is the best. So you know it is present or not because you can determine where is the testis, and where is by laparoscopy you will go for a staged operation or just one operation. And sometimes you can find it atrophied in the inguinal ligament, and you don't go for the laparoscopy, you go for open inguinal area. You can go through an inguinal incision without laparoscopy. So actually CT is the most accurate here, but sure, he will not confuse you and he will not give you both answers at the same question. Okay, next question. Dr. Shi.
A 34-year-old man from Zimbabwe is admitted with abdominal pain to the emergency department. An abdominal X-ray reveals urinary bladder calcification. What is the most likely cause? It's E. Schistosoma hematobium.
E or A?
E.
E. Okay. So urinary bladder calcification from an endemic area with schistosoma. It will be something like schistosoma or schistosoma, and schistosoma is is the schistosoma of the GIT with the core of the rectum, and schistosoma hematobium is the one of the urinary tract. Schistosoma hepatobium. Okay, next question, Dr. Nashid.
A 43-year-old female has undergone a renal transplant 12 months previously. Over the past few weeks, there have been concerns about deteriorating renal function. What is the most useful investigation? Renal function. MAC3 renogram.
Exactly. I think we cleared about this, yeah?
Yes.
Yes.
Renal function and post-transplant. By the way, post-transplant is the best investigation is MAG3 renogram. I think it's clear now, yeah? So function, MAG3, scarring, pelviureteric junction, obstruction, ureteric vesicle, backflow or reflux. We will go for Dimsa scan. Okay?
Yes.
Next question. Again, start Dr. Abu Yazid.
Okay. 24-year-old man present with persistent and unwanted erection that has been present for previous 6 hours. On examination, the penis is rigid and tender. Aspiration of blood from corpus cavernosa show dark blood. Which of the following is most appropriate initial management? Aspirate further blood from the corpus cavernosa and attempt to decompression.
Exactly.
C.
This is one of the causes of congestion. Yes, exactly. Congestion of unwanted erection. You have two types of blood you will aspirate. You will aspirate dark blood, and this is what's called the low flow periapism, and we will have what's called high flow periapism. High flow means there is fresh blood coming, so you'll find the blood more fresh and more red. Okay, so aspiration of further blood from the corpus cavernosum will be the best action for this.
Yes.
Okay, next question, Dr. Basharat. Okay, I unmuted. Okay, unmute yourself, yes. Dr. Basharat, ready?
Yes. A 68-year-old man has an transitional cell carcinoma of the bladder. He has a right hydronephrosis detected on the ultrasound and deteriorating renal function. A Dimsa scan shows a non-functioning left kidney. At cystoscopy, the ureteric orifice cannot be readily accessed. What is the best course of action? Insertion of an antigrade urethral stent. Yes, A.
Exactly.
We'll go
So
for A.
if you can't, yes, you have hydronephrosis and you want to relieve, and you can't by cystoscopy, you can't see or you can't reach the ureteric orifice, so you go for antigrade. Just not to confuse between antigrade and retrograde. Antigrade, you will go with the normal pathway of the urine. This is anti, means normal. Retro means on the other way or in the reverse of the pathway. Okay, because sometimes it's confusing for some of our friends. What is the difference between anti and retro? Yes, like the same as ERCP, endoscopic retrograde, we go on the reverse pathway of the normal bile pathway. This is retrograde, what we do, okay?
Okay.
Next question, Dr. Shi. Okay, sorry, unmute yourself.
Okay. A 16-year-old boy presents with renal colic. His parents both have similar history of the condition. His urine tests positive for blood. A KUB-style X-ray shows a relatively radiodense stone in the region of mid-ureter. What is the most likely composition of the stone? D. Cystine stone.
Yes.
Cystine. So, radiodense stone was the because her parents both have similar history of this condition. So why?
Because it's hereditary, so we have the history, the family history of the parents having the stone.
Okay, so
And
the
it's
key word
also
here is the parents have the similar condition. Yes, this is a metabolic or hereditary problem in cystine metabolism or cystine metabolism. So this is cystine stone. Okay.
Okay.
Next question. Dr. Nashid.
A 55-year-old man has multiple stones within the renal pelvis, including one measuring 25 millimeter in diameter. What is the most appropriate course of action? Arrange a nephrectomy, arrange a percutaneous nephrolithotomy, arrange for lithotripsy, conservative management, arrange for ureteroscopy and stone extraction. It's B, arrange a percutaneous nephrolithotomy.
Exactly. So we said more than 2 centimeter or more than 20 millimeter. We will go for the surgical open technique. Okay. Nephrectomy, okay, this is non-logic. It is not something like renal failure or tumor. PCNL, yes, exactly. Lithotripsy endoscopic, no, not accepted. It's from 1 centimeter to 2 centimeter. Conservative management, no less than 0.5, and arrange a ureteroscopy and the stone extraction is the same like lithotripsy or lithotripsy by Eswell, sorry. So all actions are not. So percutaneous nephrolysotomy is the best answer here. Next question, Dr. Abul Yazid.
Yes.
So,
A parent to bring her 4-year-old child to the surgical clinic. She has noticed an intermittent swelling in right scrotum that's worsened in the evening. On examination, he has soft, fluctuant swelling in the right scrotum that cannot be separated from the testes. It's transilluminate. When a pen torch is held against it, what's the best course of action? Um, ligation of patent process vaginalis via inguinal approach. So it's A.
okay, exactly. So what we will search here for? Child
Hydrocele.
hydrocele.
Yes.
So I'll go for what is the approach
Inguinal.
through
Inguinal
inguinal approach.
Inguinal approach.
So
Yes.
my eyes will run in the answers for the inguinal approach and see
Yes.
which one is right. So the only one, 3 scrotal, excluded, aspiration not contraindicated, and the only one is the inguinal approach is this. So we go for inguinal
A.
approach, ligation of the process vaginals.
Yes.
Next question, Dr. Basharat.
A 65-year-old man presents with significant lower urinary tract symptoms and is diagnosed as having a benign prostatic hyperplasia. Which of the following drug treatment will produce the slowest clinical response?
No.
Tamsulosin, alfuzosin, doxazosin, finasteride, and terazosin. I will go for finasteride because it effect starts very slowly. It's a 5 reductase, 5
Slowly
alpha
with
reductase
less.
inhibitor.
Exactly. All other options are alpha.
Blocker.
Or alpha, this is a 5 alpha reductase
blockers.
inhibitor.
Okay, but finasteride is the 5 alpha reductase inhibitor. The difference between two is that the alpha blockers start its action early, but has many unavoidable side effects. On the other hand, finasteride or 5 alpha reductase inhibitors start slowly, but they have less side effects and can be avoided. Okay.
Okay.
Next question. Who's Dr. Shi?
Which of the following treatment is not utilized in the treatment of overactive bladder syndrome? B? B, I'm not sure.
Not
B?
authorized. Okay.
Think is A.
It's some sort of just difficult question. Just you want to know like this. Yeah. Exactly. It is by
Exclusion.
it's not very common question and we don't have many details. Yes, we don't have many details about this. So just know that the only thing not used in treatment of our active bladder is the colpo suspension. Scrotal neuromodulation, yes, this is overactive bladder due to neuropathy. Yes, right. Botulinum toxin injection, yes, sometimes right because it's decreases the irritability of the nerves. This is what's called Botox, by the way, Botox injection. Bladder drill, yes, sometimes to decrease the irritability of the bladder due to distension and residual urine. And oxybutynin, I don't know what is it exactly, but a colpo suspension is not used in overactive bladder. Just know the question by its, just know it like this, okay? Don't go for more details that no other questions will confuse you with. No other related question for this question.
Actually, this colpo suspension is used for urinary incontinence. It is a type of a sling made to reduce the it acts as a what you call like a valve, so that urine to help in urinary incontinence.
Yes, I think so. Something like colpo is the Latin of vaginal, I think, I think so. I think corpse suspension, something like pelvic floor suspension or something like this. Maybe used for overactive
Urinary
bladder, yes.
incontinence.
Urinary incontinence, yes, exactly. But what I say is that I just want you not to confuse yourself with more details. This is okay, not used for urinary incontinence, and if the question will come with the same way. Okay, next question. Okay, whose turn? Dr. Shi.
A 43-year-old lady with episodes of recurrent urinary tract sepsis presents with a staghorn calculus of the left kidney. Her urinary pH is 7.8. A KUB X-ray shows a faint outline of the calculus. What is the most likely stone composition? Struvite, A.
Exactly. Staghorn is almost always from recurrent infection, which will release more urease, which will, yes, alkaline. You can just make it like urease, so it will metabolize urea to ammonia, so it will elevate the pH of the urine. It will be alkaline, so it will be infection. So infection, the most common stone associated with infection is Struvite stone. Okay. Next, Dr. Nashid.
A 35-year-old female is admitted to hospital with hypovolemic shock. CT abdomen reveals a hemorrhagic lesion in the right kidney. Following surgery and biopsy, this is shown to be an angiomyolipomata. What is the most likely underlying diagnosis? Neurofibromatosis, Budgie, E. Tuberous sclerosis.
Yes.
Okay. Also, this one of the questions that is just know it without any details. Tuberous sclerosis is associated with angiomyolipomata of the. Exactly. So tuberous sclerosis is the underlying diagnosis. Next question. Dr. Basharat is off. Okay, go Dr. Abu Yazid again.
Okay, 22-year-old man is participating in vigorous intercourse and suddenly feels a snap and his penis become swollen and painful. The admitting surgeon suspect a penile fracture. Which of the following is the most appropriate initial management? Immediate surgical exoperation.
Exactly. This is
once it's broken, you have
an
to correct.
emergency. Yes, you have not to correct, even you have to evacuate the hematoma from ischemia,
Yes.
because broken, it will come if you did see a broken penis before. So
Yes.
you will find
severe hematoma.
You will find severe hematoma and swollen penis around the penis and around the perineum. Immediate exploration and debridement and evacuation of the hematoma and ligation of the bleeding vessel. You know what a fracture inside a very high flow blood to the penis, and then some fracture will happen. So you will find aggressive hematoma, which will happen immediately after the fracture. So this is an emergency surgical problem. You have to go for immediate surgical exploration as well. Dr. Zaina, want to share with us? I hope so. Dr. Zaina, unmute yourself. Hello.
Hello, hey, Dr. Rami.
Hi, Dr. Zaina, where are you?
Okay.
Yalla, you left us. Okay, go fast with us. Yalla, next 3 questions, Dr. Zaina, go. Yes.
Okay. Which of the following doesn't cause radiurine? Rifampicin, phosphaturia, beetroot, rhubarb, blackberries. Phosphaturia.
Okay, all what have R will cause red urine. rifampicin, beetroot, rhubarb, and blackberries, all except phosphate, will not cause red urine. This is a unique question, by the way. No questions. Yes.
Okay.
Next question. Yalla go.
"73 years old man present with hematuria. Investigation demonstrate localized high-risk prostatic cancer. His comorbidities include the COPD and the ischemic heart disease. His staging investigations shows no evidence of metastatic disease. What is the best course of action? Transvesical prostatectomy, radical prostatectomy, external beam radiotherapy, chemotherapy alone, or chemical orchidectomy. I think this responsive to radiotherapy.
So,
C, external
C?
beam radiotherapy.
Exactly. Okay, so we have two scenarios for prostatic cancer management. Okay?
Okay.
Or we just want to summarize what's called here about prostatic cancer. Prostatic cancer, we have to take a biopsy before any intervention, especially surgical intervention. Next thing, we use Gleason classification or Gleason score for the severity and aggressiveness of the tumor. Third thing is the management. We have two management options. If the patient is fit for surgery, he will go for radical open prostatectomy, not transvesical, not URP or something like this. If the patient is unfit for surgery and has many comorbidities that may risk his life during the surgery, you will go for external beam radiation. This is summary. Yes, radiotherapy. This is summary about what you need about prostatic cancer. Okay, next question. Yalla go.
Okay. From the list below, which drug is known to cause hemorrhagic cystitis? Rifampicin, methotrexate, dexamethasone, leflunomide, cyclophosphamide. I don't know this question.
Exactly. Even you are not requested by pharma, by the way. So you will just find sporadic question about pharma, know them like this, and they are repeated in exam. Repeated in the exam, by the way. Note of the following. So rifampicin, methotrexate, dexamethasone, and leflunomide, all these cause hemorrhagic cystitis, except cyclophosphamide is not associated with hemorrhagic cystitis. Don't confuse yourself, don't go deep, don't search for more details. Really, it comes repeated with the same, and it is, by the way, it is very rare to come. Okay, just answer answer the question, and then we'll go for new participant. Yeah, read this question.
Okay. 73 years old lady undergoing chemotherapy for treatment of acute leukemia. She developed the symptoms of renal colic. Her urine test positive for blood. QB X-ray shows no evidence of stones. If a stone were present, what type could it be? Calcium oxalate stone, or calcium phosphate cysteine stone, strovate, or uric acid stone. هو مختار uric acid.
Okay, uric. Yes, exactly. Sorry, I just made some. It's my fault, not more. Okay, so you said before, any patient with cancer damaged cells with chemotherapy or radiotherapy will have a high uric acid because destruction of the DNA of the cells and tumor cells will release more what's called urea and uric acid particles, and will cause a urate stone. So if you found patient cancer or chemotherapy, the most common stone associated is the uric acid or the urate stone. Okay, so go next again, Dr. Basharat. Go.
Which of the following statement is false in relation to the renal adenocarcinoma? They account for 75 cases or 75% of the renal tumor. Renal biopsy should be performed in all cases considering for radical necropectomy. Yes. B, it should not be performed. Renal cell biopsy is not performed for any case. B,
Exactly.
The answer is
we mentioned it in the start. Exactly. We mentioned it in the start of our discussion. Most renal, on the controversy of prostatic cancer, most renal cancer are diagnosed radiologically and have features that can tell you that it is cancer or malignant or benign, and no need for, it is not a typical practice to have a biopsy from renal cancer, okay, or renal mass. Dr. Abu Yazid. Okay.
A 17-year-old man is referred to a urological clinic. As a child, he was diagnosed as having a right side PUG obstruction. However, he was lost to follow-up. Over the past 7 months, he has been complaining of recurrent episodes of right loin pain. A CT scan shows considerable renal scarring. What's the most useful investigation? MAX3 for sure. Yes.
Exactly. Some here answered A again. Dr. She said A.
Yes, sure.
Okay,
Sorry.
what we said that MAX3 Dimsa scan will give us renal scarring, and we get the same
Okay.
result with the CT. But why we go for MAX3? Because the patient will not be
Because it's the renal function.
exposed for exposed. Yes, exposed. The patient will not be exposed for radiation, so we'll go for Dimsa scan or less exposure and is more accurate. But as we did a CT and we already discovered the renal scan, so our main object now, so to know if it is functioning kidney or not functioning kidney through a MAG3. So you are playing between Dimsa scan and MAG3 only, because if you go for renal investigation, you will find many investigations, and really it is not related to our out of scope, and it's very difficult to come in the exam. Okay, but if you want to show a renal mass, the best investigation is CT. Stone, CT. Okay.
CT.
Next one, whose turn? Okay, Dr. She.
72.
Dr. She.
A 72-year-old
Okay.
man presents with lower urinary tract symptoms. On digital rectal examination, benign prostatic hyperplasia is suspected. Which of the following treatment is associated with a reduction in the risk of urinary retention? Now it's B, finasteride.
Exactly. We said that 5-alpha reductase inhibitors are least in side effect and a less common side effect with it. Otherwise, other alpha-1 reductase inhibitors may be associated with, alpha blockers may be associated with urinary retention. Okay, next one, Dr. Nashid.
A 22-year-old man is involved in a road traffic accident. He is found to have a pelvic fracture. While on the ward, the nursing staff report that he is complaining of lower abdominal pain. On examination, you find a distended tender bladder and blood at the urethral meatus. What is the best management? Suprapubic capture.
Exactly. Remember, it is contraindicated for any castration, for any patient have bloody urethra. Contraindication, part A and part B. If the patient have bladder through the urethra, contraindicated for Foley catheter. insertion. Okay.
Okay.
So suprapubic bladder. So pain relief is not, the patient may have ruptured bladder. So, and 3 Follicaster or something like this contraindicated. So suprapubic caster is the most common investigation. Okay, Dr. Zaina, again.
Okay. Which of the following procedures represent the optimal operative procedure for testicular cancer? Lourdes procedure, orchidectomy via scrotal approach, orchidectomy via inguinal, orchidectomy via compound inguinoscrotal, none of the above. Inguinal approach. Orchidectomy via inguinal
Exactly.
approach.
Any cancer, inguinal approach for high ligation and cutting of
أنا
the
lymph node
spermatic
كمان.
cord.
Okay.
Exactly. We just make more safety margin starting from the spermatic cord.
Okay.
Next question, Dr. Abu Yazid.
A 56-year-old lady reports incontinence mainly when walking the dog. A bladder theory is inconclusive. What's the most appropriate investigation? Neurodynamic study.
Exactly.
mentioned it
Just
before.
simple incontinence.
Mhm.
Yes, just simple incontinence. We doesn't mention any labor problem. We doesn't mention it is continuous. So we can say it is fistula. We don't mention that it is stress. So it happens while walking means it happens without stress, but while standing up. So urodynamic study will be the best investigation for incontinence with no other complication or associated signs. This is the 3 scenarios that you'll have about incontinence, by the way. Okay, next question, Dr. Basharat.
A 55-year-old man presents with an episode of frank hematuria and on investigation is found to have a T2 transitional cell carcinoma of the bladder. His staging investigation are negative for metastatic disease. What is the most appropriate treatment? Radical cystectomy, palliative, intravenous, BCG, intravenous, radical cystectomy.
Exactly. T1 is associated through the
Is the detrusor in the
just
outer layer of
for
detrusor, and T2 is in the layer of
mucosa.
detrusor.
So we can go for what's called
BCG.
endoscopic mucosal resection or followed by BCG. As you reach the superficial layer of the muscle in T2 or the deep layer of the muscle in T3, or you go for extravesical fat in T4, so you will go for a radical cystectomy. Is it clear? It's out
Yes.
of your scope, okay, but it's out of your scope, but just put in T1, that's limited to the mucosa, and you can go for endoscopic mucosa resection, okay, followed by BCG or any chemotherapy injection. T2 is superficial muscle, T3 deep muscle, and both of them you will go for radical cystectomy. And T4 also you have T4A and T4B, one in the some organs, one extravesical fat, and one for the some organs in the pelvis plus the pelvic muscles and all of yes. So it will be surgical radical cystectomy. Okay, clear for this. So starting from T2, as you reach the muscle, you will go for radical cystectomy. If he just said T1 and I didn't remember that I have seen it in recalls or something like this, you will go for BCG or endoscopic mucosal resection. Okay, next question. Start again, Dr. Ghazil.
56-year-old man is admitted with severe groin pain associated with hematuria. He was well until 1 week ago when he when he was unwell with diarrhea and vomiting. What's the most likely cause? Okay, diarrhea and vomiting because of dehydration. Ureteric calculus.
Exactly. Exactly. The patient symptoms is loin to groin. Loin to groin pain is a calculus.
Yes.
Loin to groin pain is a calculus. Pyelonephritis, no. Prostatitis, no. Prostatic cancer, no. Renal cancer, no. So the only thing will make for you pain, loin to groin, it will be renal calculus. Okay.
Yes.
So I think we know now why loin to groin pain. Why
Yes.
this radiating pain? Again,
Sympathetic T2, T10 to L1.
T10 to L1, same gamma then.
exactly.
Inhibition.
From the umbilicus till the inguinal and scrotal area, and the parasympathetic is through the vagus, which will cause some sort of nausea and vomiting. Okay, so loin to groin. Because, by the way, this question is in recalls 2019, and I think repeated 2 times. Why loin to groin? Because sympathetic T10 to L1. By the way, if you just need for the ureter is starting maybe from T11 or T12, but we are talking from the renal pelvis till the end of the ureter from T10 to L1, and the parasympathetic through vagus, so will cause nausea and vomiting.
Yes.
Okay, it's clear now.
Yes.
Yes.
Next question. Sorry. Okay, next question, Dr. Basharat.
A 73-year-old man has previously undergone a prostatectomy to treat prostate cancer. On review, his prostate-specific antigen has raised to 55, and he has developed pain in his lower back. Imaging shows osteosclerotic lesions in L4 and L3. What is the best treatment staging? Strategy. What is the best treatment strategy? A, posterior spinal fusion. B, vertebral body reconstruction. C, biphosphonate and radiotherapy. D, androgen suppression, biphosphonate and radiotherapy. Yes, D, by androgen suppression, biphosphonates and radiotherapy.
Exactly. In spine metastasis, you have to go for radiotherapy. Okay, in spine metastasis, whatever from pancreatic or something like this, radiotherapy is the main treatment of spine mets. And here we have 2 other problems. Is the it is osteosclerotic about the bone problem, so are giving alendronate or bisphosphonate treatment for the bone, and also we have to suppress the androgen that makes the metastasis started to appear again. So you have to give any androgen suppression treatment. So triple therapy is the most appropriate treatment for any mets in the spinal, in the vertebral column. Okay. So it will be androgen suppression, bisphosphonates or alendronates, and radiotherapy. Next question, Dr. Shi.
A 25-year-old man is admitted with left-sided loin pain that radiates to his groin. His investigations demonstrate 9 mm left-sided calculi within the proximal ureter. His renal function is normal. What is the most appropriate course of action? B. Arrange extracorporeal shockwave lithotripsy.
Exactly. Why?
Because it's in the proximal ureter, which is difficult to descend, and it's a 9 mm calculi, which makes it difficult to pass.
Okay, so we said from 0.5 till 1 centimeters as well will be the best treatment option and treatment choice. Okay.
Yes.
Next question, Dr. Nashid, then Dr.
A
Zena.
56-year-old man is admitted with acute retention of urine. He has had a recent urinary tract infection, and USS shows bilateral hydronephrosis. What is the best course of action? Retrograde ureteric stent.
Urethral catheter.
See, yes.
Hydronephrosis
So why?
shows like ureteric stent, and there is no obstruction, so we
Sorry?
can give
There is
the
acute
there is
retention.
hydronephrosis. Yes,
Okay,
and
what
there is
is the main
hydronephrosis,
cause of
so ureteric
bilateral?
stent.
Okay, what is the main cause of bilateral cause here?
Because of
There
urinary
is an
retention.
Maybe a
obstruction
bladder
from
CA, maybe a bladder CA.
lateral.
Okay, so you have something central, something central here, which is the retention due to PPH or something like this. So just you are relieving the urethral obstruction, you will have release for the bilateral hydronephrosis. When we go for the bilateral ureteric stent or something like this, when I have something inside the bladder, so he will tell you the bladder is empty and there is a mass in the bladder compressing one ureter or both of ureters. So what you will go, so this is a bilateral dual pathology closing both ureters. So you go for bilateral retrograde ureteric stent or bilateral retrograde antegrade ureteric stents, whatever, it's more easy. I think if you have a mass or tumor, you'll go for antegrade ureteric stent. But here he tell you that the patient has acute retention and bilateral hydronephrosis with recent urinary tract infection. So most common maybe stone, maybe PPH. So just urine catheter will relieve the problem. Okay.
Okay.
Right.
Next question, Dr. Zena.
32 years old male present with a swollen, painful right scrotum after being kicked in the groin area 1 hour ago. There is a painful swelling on the right scrotum and the underlying testis can't be easily palpated. What is the most likely explanation? Hydrocele, hematocele, epididymoorchitis, orchitis, epididymal cyst. Hematocele.
We explained. Okay. We said just immediately kicked in the groin, and after 1 hour he has a swelling, and you can't feel this. So something
trauma.
around the testis will be exactly history of trauma and immediate
painful,
swelling.
Immediate swelling.
The other one, it was history of trauma and the swelling 3 weeks later, and not painful. Now you can know the difference between both. Okay.
Okay.
Last question, Dr. Abu Yazid.
47-year-old woman presents with loin pain and hematuria. Urine dipstick demonstrates blood, nitrate, leukocytes, or protein. Urine culture show proteus infection, and X-ray demonstrate a staghorn calculus in the left renal pelvis. What is the most likely composition of renal stone? Struvit. C.
Exactly.
ايه الستروفيد دي يا دكتور
stone.
رمضان؟
Some sort of a stone associated with infection. Infection will organism release urease enzyme, and urease enzyme will release ammonia. Ammonia will change the acidity of the urine to make it more higher and more alkaline. So it is a good media for cervix
Infection.
infection,
Proteasis. Proteus infection.
proteus infection. Exactly. So thank
Okay.
you. Finish today all
Thank you, sir.
urology.
Thank
I
you.
hope you could benefit from this.
What is the next topic?
I hope
Topic.
next topic. I can't. I didn't make now. Sorry, can just thank you now. I just want to finish the recording, so not to take time. Thank you.